Hello again. Thank you for submitting your answers to the questionnaires. The idea behind this video is to give you the answers to the questions people commonly ask in the clinic. I'll be explaining exactly what is involved in a total hip replacement, who should have one, and what are the expected outcomes. I'll also try to answer commonly asked questions such as, are there actually any alternatives to a hip replacement? How successful is the operation? Is there a best age at which to have the operation, a best time for it to be done? Will I be pain-free? Will I be able to walk normally, or will there be any significant restrictions to my activities? To clarify the situation, I think we first need to discuss what's actually meant by hip pain. We're very fortunate in the hip world, if that's the right phrase, because abnormalities of the hip tend to be experienced with pain in the groin crease. And this is a really important distinction, as you'll see from the following discussion. The majority of people with pain in the groin crease are suffering from hip problems, and commonly this is arthritis. Arthritis is a disease process that comes on over many years, and so the pain that's associated with it can take a long time to develop. The implications of this is that the body will try to compensate as much as possible for the disease process. That's to say, other areas of the body, such as the lower back, the outer side of the thigh and the knee, may become painful because of compensation being made because of the hip. The arthritic process may also lead to hip stiffness. And a common example of this symptom is people notice they struggle in a morning to put on their socks and often have to sit on the bottom of the stairs to do so. So if this is the sort of pain that you are experiencing, it is more than likely coming from your hip. If we're considering a hip replacement, we need to be thinking about how successful it's likely to be. And the short answer is that hip replacements are in general very successful operations. Many of the patients we see coming back to the clinic after the operation tell us that they've completely forgotten they've had the operation done, the so-called forgotten hip. I've been carefully analysing the scores that patients give after the operation in liaison with the nurses in clinic. And in regard to their function and overall happiness, we assess them. In general, after 6 to 12 weeks, they're normally off crutches, mobilising well, and are pleased they had the operation done. Between 6 months and a year, many of them report that they have forgotten they've had the operation done completely. Patients often tell us that they have close friends and relatives who had hip replacements done. And almost universally, provided they haven't had any complications, they are extremely happy. It's worth mentioning, though, that this is a different experience from patients that have knee replacements, and the reason for the discrepancies are dealt with in the video on total knee replacement. So to discuss some of the specifics of outcomes following hip replacement, let's start with pain and how it changes after a total hip replacement. In order to assess pain, we generally ask patients to fill in a visual analog scale, which is a score that runs from 0, meaning no pain at all, to 10, which is the worst pain imaginable. Obviously, we're all different, but in general, if patients have pain that is a level of 8 to 9 or 10, this pain is severe. And as I mentioned, if you have a pain at this level and you're noticing it's making life miserable, that you can't do your normal activities, and worst of all, you're being kept awake at night, then I think this represents a strong indication for a total hip replacement. It will be my hope that if you underwent a hip replacement under these circumstances, all of this pain could be removed. But obviously, we can't guarantee that in every single case. As a rough figure, though, 90% of people will experience a significant relief of this pain. As has been mentioned earlier, quite a lot of patients noticed that they were getting pain in the groin, but also pain in the lower back, knee, and over the outer side of the thigh. This doesn't actually represent the hip arthritis, and in general, it's come on because of the compensatory mechanisms the body is making for hip arthritis. This means that once the hip arthritis has been operated on, and thus the cause of the problem has been removed, we would hope then that the compensatory pains would gradually settle down with time. So to go on to answer some of the common questions, the first obvious one is, are there any alternatives to hip replacement surgery? The problem is, if your hip is starting to hurt you, you will probably have seen your general practitioner, and they will be starting to give you painkillers. They are starting to work you up what's known as the analgesic ladder. This starts with fairly simple analgesics at the bottom end, such as paracetamol and ibuprofen. If these don't work, then stronger analgesics are required, including tablets or patches, but some of these have significant side effects. Quite a lot of people ask whether or not tablets like glucosamine or chondroitin sulfate are worth taking. The short answer is yes, I think they are. Whilst there isn't concrete evidence, I think they are worth trying. The unfortunate problem is, unlike knee abnormalities, there aren't any simple injectable painkillers that can be used for the hip. Another issue that comes up quite regularly in clinic is that of weight loss. Clearly, if you're carrying extra weight, this means you will put more forces through the hip and therefore it's likely to wear out more quickly. It's also the case that the operation is more technically difficult and there is a slight increase in the risk of post-operative complications. A very common question is, what's the best age at which to do a hip replacement? Obviously, the older the patient is, the less likelihood there is of the prosthesis wearing out. That said, I feel that if someone has got to the stage where life is miserable, they're being kept awake at night, then the pain is likely to have got to such a stage that a hip replacement is the only real option. A common question is, how long am I likely to be in hospital? And the short answer is approximately 3 to 4 days. But let me expand on the inpatient stay just a little bit. Immediately after the operation, the physiotherapist will closely supervise you, and we encourage you to get up and walk as soon as the spinal anaesthetic has worn off. And this is really important. Firstly, because it gives you the confidence in the new implant, but more importantly, it stops the risks of blood clots and chest infections. These can develop if you go in bed for a long period, and by mobilizing, you reduce these risks significantly. Once you are able to climb the stairs safely with crutches, and all of the home circumstances are sorted out, you'll be able to go home. In the rehabilitation of a total hip replacement, there are a small number of exercises suggested to be done whilst the patient is in bed, and these will be shown to you by the physiotherapist. But the best exercise really is trying to walk as much as you are able. It would be hoped that you will be walking without crutches or a stick by approximately 6 weeks after surgery. For the keen golfers amongst you, I would advocate they should probably be back at the driving range between 6 weeks and 12 weeks and starting to play a significant number of holes between 3 and 6 months. Another common question is, how long do hip replacements last? And to date, hip replacements are generally lasting between 15 and 20 years. Some prostheses do last longer, but I think overall 15 to 20 years is a reasonable figure. Another common question is, if I've decided to have the hip replacement, what sort of hip am I likely to get? Now, this is a question that is best addressed to the surgeon who's going to be doing the operation. But just to give you a little bit of background, you'll have probably noticed considerable coverage in the press about metal-on-metal resurfacing. About 10 years ago, it was felt that putting in a metal head against a metal cup would be the best sort of bearing surface. Over the years, some patients have had problems with this prosthesis, but there are a considerable number of them who are doing very well. At the moment, there is considerable press interest, and I would suggest to you you need to discuss this with the surgeon who's going to be doing your operation. If you decide to proceed to surgery, then you will be firstly seen in the pre-assessment clinic. This is a very important clinic run by nursing staff, junior doctors and anaesthetists, and they will assess your fitness and readiness for surgery. They will also go over the operation in detail and clarify any questions that you might have. And so to finally cover the issue of complications, there are 2 main ones that I'd like to discuss with you. The first risk is that of dislocation. In order to be able to get in and do the hip replacement, we need to cut the capsule. And quite a lot of the surgeons here at Ashford and St Peter's go in through the posterior approach. This means that the back of the capsule is weakened, and it will be for about 6 weeks after the operation. Certain precautions need to be taken, and the physiotherapists will go through all of this with you both before and at considerable length after in order to avoid dislocations. The other complication I'd like to talk to you about is the risk of infection. This is clearly something we take extremely seriously, and measures will be explained to you both before, during and after the operation, all of which we take in order to be sure that the infection risk is kept to an absolute minimum. So to finish, I hope this video has been helpful. Please feel free to rerun it however many times you want, and I hope the information you'll have gleaned will allow you to discuss hip replacements with your family and friends and come to the decision that you think is most appropriate. Thank you.